Okay, we're live streaming on YouTube.
Can you see that? Is that sharing?
Yeah, it's showing, yeah.
Great. Really, really things. Great. Oh my goodness. Live streaming. Can you see that? Is that sharing? Yeah, it's good. Right, it's going to try and play it back to us.
You can mute the window if you need to, Rick.
Yeah,
So,
I've muted it. I think I'll just leave it like that, muted.
Yep, that sounds good.
Okay, and let's try and go back to presenting again. Can you see the, still see the presentation?
No, got your head at the moment.
Right, okay. To work out which way to do it. Share screen. So it should be sharing now, I think.
It looks good.
Is it still sharing when I do that?
Yep.
We haven't got the presentation.
Oh, no, it says, okay, let me try again.
It's showing the old presentation.
Every time you put the presentation on, it says, bring your shared window to the front. So I have to stop the share and then redo it. It's awkward. Anyway, we're there now, I think. You should be able to see that now.
Yeah, that looks good.
It looks good. Yeah. Let's get them in.
Okay, so it's 1 minute to. I'll just pause for a minute and then I'll start at 11 o'clock.
I'm going to get a really quick coffee.
Morning, everybody. Welcome to the COVID-19 Journal Club, brought to you by Manchester Royal Infirmary and the Royal College of Emergency Medicine. It's a pleasure that you could join us again for another deep dive, looking at one paper in depth and then 5 rapid fire papers. And we've got another expert faculty. We're really pleased to have even strengthened it further this week. So we've got the same cast as last week, myself, Simon Carley, we've got Anissa Jaffar and Charlie Reynard. We've got our 2 professors of medical virology, Pam Vallely and Paul Clapper. And we're really pleased to be joined by Casey Parker as well from Broome, from the Broome Docs, which I'm sure you will, of course, know. So I'll just hand over to Casey to give us a quick introduction in 1 moment. But first of all, just to go through the instructions for the webinar again. So we're going to present the evidence on the papers, but if you have any papers, any questions as we're going through, please use the Q&A function. You can type your question in and we'll answer it either typed or live. You can feel free as well to use the chat function, and please do let us know if there are any audio visual issues as we're going through so that we can try and correct them before it's too late. So I've given a brief intro to everybody. If you joined us last week, you'll have met the faculty, but you won't have met Casey. He wasn't here last week. So Casey, do you want to give us a quick introduction?
G'day, Rick. Thanks for the invite. I'm a GP from the far north of Western Australia, and I run a podcast and blog, which is all about evidence-based medicine. And we do a monthly, roughly, journal club with my friend Justin in Canada. So this is the sort of thing that we get our teeth into regularly. So looking forward to it.
Rick,
brilliant. Thanks a lot for joining us. Simon.
Have you let everybody in, or are they in the waiting room on the Zoom?
I don't think we have a waiting room function.
Okay, so we've only got 7 participants. Is that right?
We have no attendees, apparently. So that's a good point. So I'm not sure why that's the case.
Janos has just said that his Zoom link isn't working.
His link isn't working.
Nope.
Have they gone into a different
webinar?
Yeah. Have you got more than one webinar?
So unless they registered for a different week, because we set it up for several weeks at the same time. So I'm going to pause the recording, I think. Can anyone join it via that link on the phone?
YouTube,
I'm going to try.
YouTube is working, but everybody's saying that the link isn't working.
Right, okay. Apologies for that, everybody. I don't know what's happened with Zoom. I'm going to try and sort that out. Can anyone else have any success with it?
No.
Oh, well, I think we'll probably carry on and let it stream on YouTube, and then we'll put the recording out.
Yeah, sure.
Unless...
Should we direct people to the YouTube on Twitter then, and ask them to use a certain hashtag or something so we can pull questions in from Twitter?
Yeah, sounds good.
All right. Smashing.
Rachel sent a picture of everyone watching at the hospital, so we're connecting.
So this conversation is going out on YouTube, which is hilarious. So yeah, I think we should crack on, and then we can edit it back and go from there. And I'll just send a quick thing out on Twitter to say we're just going to use the YouTube link.
Yeah. Okay. So we'll crack on with the first paper. So this week we've got a randomized controlled trial of hydroxychloroquine, which is fantastic because there's lots of hype about hydroxychloroquine. I ran a webinar with USEM this week, did a poll to find out what people were using for treatment of COVID-19 across Europe, and the majority of people said that they were using hydroxychloroquine. So Anissa, you're going to take us through this latest evidence to see if we're right to be using hydroxychloroquine.
Thanks, Rick. So yeah, as pointed out, really by the authors themselves, we're very much learning on the go during the COVID-19 pandemic, and therapeutic arsenals are very limited. And the number of antivirals that are potentially going to be useful, sort of falling a bit like soldiers as we move forward. But there's a lot of hype remains around the hydroxychloroquine, and that's partly come about because of the in vitro activity against the COVID-19, but obviously previous experience with SARS and MERS. And in terms of the effect that it's supposed to have, there's queries around viral entry and viral replication, but it's as yet not fully confirmed as to how it has that activity. So it's a very important question that's been posed by the study team, and it's the first multi-centre randomised control trial that we have available to us, looking at the use of hydroxychloroquine for the COVID-19. Now, one quote from the paper, which does highlight the importance of this specific study and others like it, and the quote was, hydroxychloroquine was recently recommended by the American President Donald Trump. Such a presidential endorsement stimulates an avalanche of demand for hydroxychloroquine, which buried the dark side of the drug. And it's that's got to be remembered, that it's not a drug without side effects such as retinopathy, GI side effects, and cardiac side effects. So this study was intended to look at safety and efficacy. And so let's have a quick look at the methods. I think, Rick, do you have to click forward, or can I do that? I'll try. I can't. I think it has to be you, Rick. Oh, there we go. So as I've said, it's a multi-centre open label randomised control trial, which involved the administration of hydroxychloroquine to 150 patients were in the intention to treat, and they were patients who were hospitalised with COVID-19. It was carried out at 16 government designated COVID-19 treatment centres from 3 provinces in China, Hubei, Henan and Anhui provinces. The hydroxychloroquine was given at quite a high dose. It was 1.2 grams daily for 3 days, followed by 800 milligrams daily for 2 to 3 weeks. So a large dose and a reasonable length of treatment. And the primary outcome they were looking at was viral clearance by day 28. There were a whole host of secondary outcomes, including resolution of clinical signs and symptoms, so signs including reduction in fever, oxygen saturations maintaining above 94%, and then losing of the respiratory symptoms. There was an attempt to look at resolution of radiological findings, but there were some issues with that as the study went on. And then they looked at lab parameters such as CRP, ESR, IL-6, TNF-alpha. And then as time went on, they looked more specifically at moderate and severe cases and thinking about things like mechanical ventilation, ECMO, again, oxygen use and hospital stay. They took information at days 4, 7, 10, 14, 21 and 28. And the initial sample size was powered at 80% for 360 subjects with the intention of an interim analysis at 150 subjects. We can discuss that a little bit more later. And those included in the study had to be 18 or over. They had to have ongoing COVID-19 infection, which was confirmed by RT-PCR. And they had to make an agreement not to enter any other trials. Anyone that had an allergy to hydroxychloroquine obviously was excluded. Those with severe liver and renal disease were also excluded. If they were unable to consent or fully cooperate due to cognitive impairment, they were also removed from the trial, as were pregnant and lactating patients. So if we can flip forward, yeah, I think we just click forward into the next slide. So if we look at the table of patient characteristics, by and large, they were a well-matched control and intervention group. Overall mean age of 46, 55% male. The severity of the group were mostly mild or moderate. The only areas of signal which might be interesting to think about, and they don't necessarily show up or get discussed in a great level of detail, there's just a comparison of the numbers in the mild and moderate group between the two groups. In the hydroxychloroquine group, there appeared to be more of the mild and less of the moderate, but again, it's difficult to look at the numbers in the raw form. And the only other area that I thought was a little bit interesting was the coexisting conditions, because there appear to be more comorbidities in the hydroxychloroquine group. Again, that's something we just have to bear in mind. We can't always take the raw numbers at face value. We'll just click forward. And the other area, again, to draw attention to, so the laboratory findings were almost identical at baseline. There was really nothing to pull the two groups apart. The other area I thought was, again, potentially a little bit interesting. If we look at the cough, sputum production, shortness of breath numbers in the hydroxychloroquine group, there seem to be more symptoms of that nature in that group compared to the other. And again, that's just focusing on purely raw numbers. So again, just something to bear in the back of our minds. Click forward. So the overall results were unfortunately a little bit disappointing. There was no significant difference in viral clearance at 28 days. And all told, when we look at all of the paper in its full glory, no really significant difference in any symptoms, signs and laboratory values. There was a hint at some signal around CRP, but that's a little bit dubious. And we have to bear in mind a little bit that there was a fairly late administration of hydroxychloroquine. It was around 16 to 17 days on average. And so there may be something in that. And the other thing to bear in mind from this study was that 30% of the hydroxychloroquine group did suffer some adverse events, mainly GI. And there were a couple of patients who had to have fairly severe adverse events, which were reversible. But it is, again, something we need to think about based on the result of this study. How do we move forward? Can we move to the next slide? So I'll open up to panel discussion just now.
So thanks for that, Anissa. Really interesting. No signal to benefit whatsoever. So it goes against what we looked at with Gotray et al., where they found in a non-randomized study some proposed benefits of hydroxychloroquine. This is the largest RCT so far of hydroxychloroquine and no benefit. So what do we make of that then? So maybe I'll go to Paul first to go for a virology opinion. I mean, the hydroxychloroquine was proposed to have in vitro effects, reducing the acidity of the endosome, stopping the virus from getting properly into the cell and replicating, but so far not proven to be the case. What do you make of it, Paul?
Well, we've seen this before. If you go back to influenza and amantadine treatment, that was supposed to work by acting on preventing the emergence of influenza from the endosome, and it's not a very effective antiviral at all. So there may be some in vitro activity, but it's minor, I think. And the main thing that came from this was really that there's no effect on viral replication, and that's the hallmark of whether it has antiviral activity or not. It has an effect on symptoms, and that may be its anti-inflammatory effect. Yeah, Casey wants to say something.
Yeah, Casey.
Yeah, it's quite interesting when you look at those numbers and they talk about in their secondary outcomes, symptomatic improvement of patients, which is something that would be really great if it were true, that we could help patients feel better. But as Anissa pointed out, the patients weren't really clearly matched in their cohort groups beforehand. It seemed that the patients in the hydroxychloroquine group had worse symptoms before the trial. And a lot of the outcomes that they were on a post hoc analysis where they sort of adjusted a few things for other drugs that were involved. So I'm not too sure we can hang too much weight on that symptomatic improvement from this trial. Small numbers and a bit of post hoc analysis, a mismatched group going in. So I'm going to be skeptical of that result.
Yeah, absolutely. Yeah, it was pleasing to see that they emphasised the primary outcome results in the abstract, which were negative, rather than hanging on to these exploratory post hoc analyses. Simon, what do you make of it from a clinical perspective?
Well, from a clinical perspective, I think it's right that we're skeptical that we don't necessarily believe the results, but I still think we're in an unproven area with this. This isn't a great design trial, and we still, I think, need to look for further evidence. I mean, 75 patients in each group. It's quite a broad group of patients that they recruited of varying different severities. And I just don't think there's enough here at all. The fact that we've not found a signal is as unsurprising as if we had found a signal in this group, really. So I'm not sure it's taken us much further down the line. What I do think is fascinating is the fact that this trial and some of the other trials have led to large numbers of patients being treated with hydroxychloroquine. And there are people who would look at this trial and say, well, actually, nobody died of hydroxychloroquine poisoning. Therefore, we should just give it anyway. And yeah, that's not science. And there's the bit I'm finding quite frustrating at the moment. It reminds me of vitamin C trials around sepsis, that there was a big buzz around these sort of things. And you think, well, what harm can we do? Let's give it. No, I think this is further evidence that we need to continue. And I'm going to say it, I said it last week, the recovery trial is recruiting in the UK. We've now got over 6,000 patients randomized with COVID-19. And one of the arms in that is hydroxychloroquine. And we may well get an answer on that by June with several thousand patients. That's what we need here.
It's worth bearing in mind in the meantime, while we're waiting for that high level evidence from big RCTs like Recovery, that this isn't the first negative trial of hydroxychloroquine for COVID-19. There are actually a couple of smaller trials, and 64, 32 patients that have also been negative. So apart from that one study by Gautre et al., where we recognize so many limitations because of the non-randomized design and so many biases that would be introduced, actually, we're not getting even any signal towards benefit with hydroxychloroquine.
Well, just a quick one then. Anissa, I know you're not too busy this afternoon. Do you fancy doing the meta-analysis on all those trials Rick's just mentioned?
Oh, yeah, sure.
Okay, fine. I'll see the first draft tonight.
So I guess to broaden the discussion a little bit from hydroxychloroquine, this is obviously really disappointing because we've got a condition here with no treatment. And in the meantime, we've got to do something for these patients. We saw the negative trial of lopinavir ritonavir. We've got dubious benefit with ventilation even. What are we going to do in the meantime while we're waiting for some evidence for these patients?
Do no harm. Make sure that we're not getting, like Simon said, make sure we're not giving any of these experimental drugs on poor evidence, low level evidence, and that we maintain perspective on the equipoise that we find ourselves in, and focus on the things that we do know help, which isn't very much.
Yeah, I agree. I have to say my approach has become quite minimalist for these patients because we don't know of anything that really works. So gentle supportive therapy with oxygen, looking after the basic things and doing that as well as we possibly can seems to be as much as we can realistically offer at the moment. Casey?
Yeah, sorry, just to follow on from Simon's point there about what we do and don't know with these small trials. You've got to remember these are open label trials, and so normally when we see an open label trial, you would actually expect some placebo effect to give us maybe a false benefit, but we're not even seeing that in this trial, which makes me a little bit worried that possibly there is a signal towards harm and it's being balanced out by that non-placebo effect. I guess the other thing to say is that, as you mentioned, there's a big trial going on in the UK at the moment, and it'll be excellent, but you can't take any safety data out of a trial of 150 patients because we know that side effects are, 1 in 1,000, 1 in 10,000, and serious side effects even rarer. So you need a big trial to prove that. So I think you can be falsely reassured by saying there's no significant harm in these small trials.
I think that's a really important point, Casey, because some of the reaction I've heard from this trial is that, well, they used really high doses and they didn't get a signal towards adverse effects. So at least we're not seeing that it's doing any harm. But as you just pointed out, we can't necessarily trust that to say that there is no harm with this treatment because it's a small sample. And as you say, the absence of a placebo effect might be disguising a harm that we were unable to measure. Anissa, any last comments on the paper before we move on to our rapid fire round?
No, and I think the only thing I would highlight is, I think you did point it out, Rick, that the credit in some ways to the authors for not trying to run away with this. And their, the final line of their conclusion was, and we argue about the well-tolerated but cheap and widely available drug, the suggestion from them is future trials, not let's start using it. And I think credit to them for holding back and actually suggesting future trials as opposed to anything more than that.
Great. And then just before we move on, I'll just come to Pam to talk about new treatments for a moment. So obviously disappointing evidence about hydroxychloroquine. As I mentioned, the antiretrovirals had disappointing evidence. Pam, if you were into betting on COVID-19, what would you hang your hat on as a potential new treatment?
I'm not even going to go there.
We've seen it.
I've seen too early on. There's too many unknowns at the moment. I don't know. I don't want to say.
Fair enough. A fair point. I was having a look at some of the protective treatments that are in the pipeline, and there's the convalescent plasma therapy that's being used on a compassionate basis in some places. I think there may be a trial in the United States, and that could be potentially quite interesting because that could potentially use the protective antibodies of people who gained immunity to prevent the virus from getting entry into the cell in the first place. And I saw about the camostat mesylate. I've no idea if I pronounced that right, but this is inhibiting TMPSSR1. I think I've got that acronym wrong. But this proteolyzes the ACE2, the spike protein, so that after it's bound to the ACE2 receptor in the cell and mediates entry of the virus into the cell. And that sounded quite interesting as a treatment, but of course, no evidence yet. I wondered if theoretically they might be promising treatments at least.
Yeah, I think in theory, a lot of these things, and it's certainly, around getting the virus into the cell or preventing the virus getting into the cell, preventing replication when it gets in there. All of these things are potential areas that need to be looked at, but we just haven't got the evidence yet. So.
Great. Okay. Thank you very much. So that's fantastic, Anissa. Thanks for a brilliant presentation of that paper. Let's move on to our rapid fire round. We've got 5 papers that we're going to go through quickly for you now in the remaining 38 minutes of the webinar. So first of all, we're going to go to Charlie Reynard. And I'd like to say, Charlie, thanks to you, because you put these presentations together for us both weeks. You've coordinated the RChem top 5s. You've done a fantastic job of bringing this together. I just wanted to recognise that. And you're also going to take us through this next paper, which is about looking at antibody seroprevalence in California.
Oh, well, thanks, Rick. Now, to be honest, there's about 10 or 15 people, some of them here, some of them not, who are really doing a sterling job at helping drive us forward. So it's not just me, it's a bit of a team, but thank you. So this is a preprint publication, COVID-19 antibody seroprevalence in California. This was done by the University of Stanford, and they wanted to see how many people in the community have antibodies to COVID-19, to SARS-CoV-2. They used a testing kit, which is important to focus on, which I'll just talk briefly about. It's a lateral flow immunochromatography kit, which is the same sort of tech as goes into pregnancy tests. But it's not particularly well validated, and including their validation they've done in this paper, it's only been validated on about just over 500 patients. To validate it here, they used a new ELISA assay from Stanford. They then cross-validated that with PCR swabs that were positive, which is a test that we know isn't perfect in and of itself, and then used negative controls from before the pandemic. And they did that because they weren't sure that the PCR swabs that were negative were actually negative. So there's a really convoluted validation process they went through to say whether or not these kits worked in the first place, which is a weakness we'll come back to later. So what did they do? They put an advert out via Facebook, which was novel and interesting, and they enrolled 3,300 patients, and they went for a representative study of the geographical area. Of those 3,300 patients, they found 50 who were kit positive, 50 who had antibodies detected by this kit for SARS-CoV-2. That, with an adjusted prevalence, that gave them a prevalence of between 2.5% to 4.1%. So 2.5 to 4.1% of Santa Clara residents, by their calculations, have antibodies to SARS-CoV-2. They then did some back of the envelope calculations and extrapolated that out to the whole population, and they came up with stats of it being between 48 to 81,000 people in early April who had this antibody, had been exposed to SARS-CoV-2. That's 41 to 81,000 people compared to the official testing stats of 956. So, as what this paper to me tells me is, one, the disease is spreading beyond the official stats, which we all kind of knew, but two, it highlights the difficulty in doing these tests so early in the pandemic, so early in the science of the pandemic, because we just don't know how good the tests we're using are.
Fantastic. Thanks, Charlie. So a really interesting study. I was interested that such a low prevalence in a way at the moment with that. I mean, California doesn't seem to be badly affected by this so far. I think 28,000 cases, and a population of 39 million. So compared to us in the UK, where we've got 130,000 cases and 67 million, they don't seem to be anywhere nearly as badly affected as the UK, for example. But it seemed like a low percentage to me.
Yeah. Just a word of caution. Sorry, am I on? Just a word of caution about all the antibody tests. There are about 70, I think, in being investigated in the States, and probably 200 around the world. The problem is about specificity. We have had coronaviruses circulating as common colds and occasional causes of diarrheal disease. The question is, do these tests pick up the previously circulating coronavirus and declare them as positive? There are two problems. These tests will detect IgM antibody, which is the first antibody which arises after a virus infection. But of course, the IgM antibody is broadly cross-reactive, and it's possible that it will cross-react with other respiratory infections. The IgG, which is the long-lived antibody, is more specific, but it could be that we are seeing cross-reaction with the existing pool of antibody within the population. So the results may not be particularly good. The evaluations that have been done in this country suggest there are problems with both sensitivity of the tests and also specificity. And we don't yet have a really good sensitive and specific antibody assay. And just a word of caution, going back to the early days of HIV infection, when that was discovered, we got antibody tests fairly quickly. It took another 12 to 15 years to get really specific antibody tests. Same with hepatitis C, when that arose. It took nearly 10 years to get really good specific antibody tests. So it may take us a while to get a good combination of tests that will give us specificity and give us the true prevalence of the population. It's not going to be like Mr. Hancock suggested, that we'll buy 3.5 million of these kits and be able to test prevalence in the community straight away. It's going to take some work, I think. And it's a global effort now to try and get specific antibody tests. They will come, but it's going to take a little while. So I think the prevalence in California is good. It was low, but they did say they only had about 1,000 identified cases in the county at that time. So maybe it was just the start. It was interesting. They had an old, state epidemiologist from Sweden on the television this morning, putting down Piers Morgan, which I thought was excellent. But he was suggesting that in Stockholm, they were expecting to achieve 80% prevalence of antibodies by mid-May. And they didn't tease out from him how he'd arrived at those figures and what antibody tests he was using. But there's one of the later papers where they do have specific antibody testing, which we can describe in one of the later papers. But this one, I would be a bit suspicious about the results with.
Brilliant. Well, that's fantastic to have those insights. There's a load of hype about these antibody tests. So yeah, for anybody watching this, that gives us a fantastic insight into what we can really expect from them, and make sure our expectations are aligned with reality. Thanks for taking us through that one, Charlie. Shall we move on, if I can, to the next paper? So Pam, you're going to take us through this one, a virology paper looking at virological assessment of hospitalised patients with COVID-19.
I will, and can I just apologise in advance? I've got quite a lot of children and dogs in the background. I'm trying to keep them quiet, but hopefully it'll be okay. Okay, yeah, so this is a paper from a German lab, Christian Drosten's lab in Munich. And I think there was some input from lab in Cambridge as well. It presents a very detailed virological assessment of only 9 patients. None of them were elderly. 3 have had comorbidities, including one with COPD. And they all had relatively mild disease, but they were all hospitalised and they all recovered. So it's a different look at some of the other studies that have been done. So they were all diagnosed by reverse transcriptase PCR and from a nose or a throat swab. And incidentally, they found no difference in sensitivity between the nose and the throat swab. I think somebody had asked that question on the webinar last week and we didn't answer it. They present very good evidence that this virus, SARS-CoV-2, in contrast to SARS, is able to actively replicate in the upper respiratory tract. They've done some nice work looking at subgenomic RNA, which is an indicator of replicating virus. That's important because we know that the upper respiratory tract has got low levels of the ACE2 receptor compared to the lower respiratory tract, and SARS certainly was a lower respiratory tract disease. This seems to be both upper respiratory tract and in some cases into the lower respiratory tract as well. And they propose that the reason that SARS-2 can replicate in the upper respiratory tract is that it's got a polybasic furin type cleavage site inserted into the junction in the spike protein, the S1S2 junction in the CoV-2 spike protein, and that's not present in SARS. And that type of insertion into the protein has been shown to lead to a bit of an increase in fusion activity of the virus. So that allows the virus to sort of get entry into the cell more easily, and it might explain why COVID-2 can replicate in the upper respiratory tract, whereas SARS couldn't particularly. Incidentally, that probably explains why so many people are reporting a loss of taste and smell with this disease. They found that active viral replication also occurs in the gut, but interestingly, they couldn't detect any live virus in stool, and I've read a few other papers that say that as well. So possibly the virus is replicating in the gut, but being destroyed in the stomach environment in the acid. We need more studies on that, really. There was also no virus isolated from the urine or from serum. They also looked for the presence of antibody, IgG and IgM, and they found that by day 7 after the onset of symptoms, half of the patients, 50% of the patients, had seroconverted, so they had antibody present. And in fact, all 9 of the patients had seroconverted by day 14. And they all had a detectable titer of neutralizing antibody. But there was no correlation between the titer and the clinical course. So, patients with slightly more severe disease didn't seem to have more antibody or less antibody. And, as Paul mentioned earlier, they also found that the antibody was cross-reacting against endemic circulating coronaviruses in several of the patients. They also tested the patients for lots of other circulating viruses, respiratory viruses, and interestingly, didn't find any other co-infections in these 9 patients, which is interesting. Really important is that the presence of antibody was not associated with an end to the viral load in sputum. So there was no sort of clear correlation between antibody appearing and virus going away in sputum. Instead, there seemed to be a slow and a steady decline in sputum. And one of the patients, you could still detect virus 28 days after the onset of symptoms. So, I think really important take-home message from this is that ongoing replication in sputum could be problematic for infection control and of the early release of patients who appear well. And they state that based on the present findings in this paper, early discharge with ensuring home isolation should be chosen for patients who are beyond day 10 of symptoms with less than 100,000 viral RNA copies per mil of sputum. And both of those criteria predict, if you can meet both of those criteria, then there's little residual risk of infectivity from the patient. So I thought it was a really good overall study of virological aspects of these individual patients with relatively mild disease.
Wow, some really interesting insights from 9 patients there. Fantastic. Simon, you want to come in?
Well, it's just the implications of this, I think, for those of us who work in hospitals. We're very, very worried at the moment about nosocomial infections between staff members. And of course, we're also a very high risk of getting the disease. And I'm now working with people who've been COVID positive. This seems to give a message that saying that just stay away for 7 days or stay away for 14 days is probably a bit risky, and that people will be coming back infected. Is that right, Paul and Pam?
The nice thing about this study is it's one of the few where they've actually cultured the virus, and culture of virus is really the only way we can look at infectivity. And what they were saying was that this 7-day period, you're still shedding virus, so you can pick up viral RNA, but that in terms of infectivity, once you got to 7 days, the infectivity drops off dramatically, and therefore your risk of infection drops dramatically. So the 7-day advice that's been given out is probably correct for mild disease. That's the thing to emphasize. This is looking at mild infections. So the normal ones, the sort of extra hospital infections, that's good advice, I think. Well, I don't think we yet got the study in severely ill patients to actually tell us what's happening with these patients that you have in an intensive care unit. And that work needs to come and be published.
Yeah, I think that all of that's absolutely right. I think, this is really the first sort of proper evidence that we've had that the appearance of antibody doesn't correlate with disappearance of virus.
Yeah.
Should we be measuring viral load in people before we end self-isolation?
Well, what they're saying in this paper is that viral load by itself doesn't work. In the mild cases, what we need is the data where they've done the virus isolation with viral load studies in hospitalized patients. Now, I'm sure that's data's coming from Germany, but we haven't yet got our hands on it. So we don't know yet. Most of the studies that came from China were about viral load, about RNA detection, rather than actually looking at the infectivity in relation to the viral load.
Right. I was also interested to see about the excretion in feces. It's not the only study to have identified that, and that there's actually some shedding in feces for quite some time after infection. So emphasises the potential for fecal-oral route as a mode of transmission.
That would fit with most coronaviruses, that you do get fecal-oral transmission of it. But in this study, they're suggesting that actually the infectivity, there is no infectivity in the fecal samples, that it's mainly spread by oral transmission. And that's unusual. And the way they've done that is with culture and also looking for RNA transcripts. It suggests there is some replication in the gut, but it's not actually resulting in infectious virus appearing in the stool specimens. It's a really interesting study of 9 patients.
That's brilliant. That's fascinating. Thanks so much, because you've really helped us to make sense of that. Brilliant paper and use of data from 9 patients, as you say. So the next paper that we're going to move on to is going to be presented by Anissa. So Anissa, you may know, has an interest in global health. That's what she's done a PhD around. And Anissa, this is not published in a journal, but you've thought of outside the box, really, to find this really nice piece published by the London School of Hygiene and Tropical Medicine on the guidance that we might follow in camps and camp-like settings.
Yes, it's a bit of a shift really from sort of the hard science, but it's in many ways no less useful. So a bit of a practical shift. So it takes a bit of a different perspective. And the reason I wanted to bring this particular paper, number one, to sort of highlight the sort of wider global implications and a slightly different setting than obviously our relatively high income and higher resource scenario. But there are some lessons from within the sort of humanitarian response and low resource settings which are potentially useful to sort of take on in our own settings. And specifically around this is the area of sort of being responsive to need and being a bit horizontal in our approach to planning. And this will hopefully come out as I sort of brief you on this document. So I think anyone who's got a bit of an interest we call it global health, but we mentioned this previously. This whole thing is global. You know, the papers that we're discussing are not from the UK; they're global. But we're thinking here specifically about low middle income countries, low resource settings, and how that potentially differs from what we're used to. So this paper looks at the general principles of shielding for refugees, internally displaced persons in camp-like settings. It talks about who should be shielded, how to create shielding zones in different settings. So this is a very practical, difficult thing to achieve. It also focuses a little bit on community engagement in this process, and that's something that we perhaps ought to think a little bit about, even in the UK setting. If we look at the government approach, which has been a fairly command and control vertical approach to the way that we've managed isolation, because we have the privilege of having a community setup that allows for that. But as we all know, that in terms of adherence, there have been a few anomalous approaches. It discusses the setup of the shielding zones, how you manage symptomatic residents of those zones, and then how you actually manage distribution of commodities and provide healthcare. It's a document that's intended, and this is where it differs a little bit, I suppose, from some of the academics work that we spend our time focusing upon. It's intended for the displaced community itself, as well as the humanitarian actors and those involved in coordination and management. So it's a very open document, as I say, very practical. It draws on evidence, but it is designed very much for practical use. So why are camp-like settings so special? And lots of it goes without saying. They are potentially overcrowded. They have often poor access to safe water and sanitation, and often poor access to health services. And obviously the health status of those living in those settings, based on obviously previous scenario of actually getting there in the first place, is likely to be problematic. So you've got a bit of a perfect storm for spreading, and also for putting those at highest risk, increasing the chance of them being exposed to the virus. And the other issue you have in that sort of scenario is that this mass stay-at-home order isn't necessarily going to work, and the social distancing, self-isolation and quarantine that we would be experiencing in the UK particularly are highly likely to be unfeasible. And the actual impact on livelihoods of that approach, I mean, obviously we're going to see it in the UK, we are seeing it in the UK, but it will be much more direct and make it immediately unfeasible in certain of these camp-like settings. You would require such high compliance of all of those measures that I've just mentioned to lower transmission that it would become impossible and actually almost pointless to roll out. And so the focus of this document is about shielding and suggesting that is much more efficacious. And it discusses around how you create green zones at a household level, a neighbourhood level and a camp level. And again, this is interesting from camp-like settings, but also thinking about what's going on in our own communities and whether there's anything that we could draw on in the UK. Certainly at the moment, obviously we've taken a specific lockdown approach, but as we come out of lockdown, whether there are models from this setting that you could apply to kind of bring us out in a staged way. And that really the attempt of this document is to just avoid those at highest risk coming into contact with the virus as much as possible, whether that's via interaction with other people, but also with contaminated food, water and other fomites. The two key aspects to it are very much community acceptance and involvement, good communication, good information and non-coerciveness. Now, the interesting part about that is if we think about how certain aspects of the pandemic have been managed, we haven't always had a scenario of fantastic communication and the best information and perhaps lack of coerciveness. So we are in a different scenario in the UK, that is sure. This community acceptance and involvement has been really, really key to making these measures successful. And the other aspect is sufficient support to the shielded residents and caregivers. So it's fine shielding people, but there needs to be a focus on being able to provide what they need in order, for that to be successful. And this is another thing that we could potentially learn a little bit more from in our own setting in the UK. Well, the final bit I want to just draw your attention to is the decision about which household members meet the inclusion criteria for shielding, who should be allocated to the green zone, and how all of this is set up, again, in an ideal setting is pushed out to the community. So it's not done in a top-down approach, it's done in discussion. So again, it's much more likely to be accepted. There are very specific considerations. Obviously, if you have children in camp-like settings, there needs to be some accompaniment by at least a single caregiver. Individuals with tuberculosis have to be considered for isolation separately. Obviously, they're at high risk of COVID potentially, but also there is high risk of spreading tuberculosis itself. So that's a specific consideration. And then there's a lot of mention around mental health considerations and those who've undergone sexual, physical abuse and how you actually manage that shielding. And one line that they do put in there is that there's no mandatory green zoning. If somebody opts to not remain in the green zone and has taken the informed decision to be exposed, that is something that has to be accepted. So really the lessons to learn, I think, from this document, much as it is interesting, is the question as to how horizontal are our own approaches, and not necessarily from a societal level, but even from a hospital level, because we seem to flip very much into the major incident command and control vertical top-down approach. And there may be something to learn here from the humanitarian sector about a more horizontal approach, even to hospital management, as much as we think about community management. And this community engagement is potentially going to be more important than we think it would be in our sort of high income settings. The final point on this before I bring everybody else in, there is a UK group of healthcare workers with a mix of NHS and humanitarian experience who are trying to marry up these connections, and I've put the Twitter handle down below, so if anyone's interested, take a look there at the work they've been doing, because it is really interesting and does pull this together a little bit.
Brilliant, thanks Anissa. So not our typical journal article to appraise, but loads of really interesting points about how we can shelter at-risk individuals in these settings, and also maybe apply it to our own settings. Anyone want to come in to comment on the paper?
Yeah, I think that the situation in camps is absolutely awful, because you've got people who have suffered malnutrition and stress on the way to the camp, and they're living in terrible conditions in the camp. So they are all, to a certain extent, high risk. You know, you expect them to all have depressed immunity, and that when you introduce this virus into that environment, it must be absolutely appalling trying to cope with it. And the idea of even creating green zones within the camp seemed, wow, be difficult to do. But I think you're also absolutely right. I mean, as we progress with this, there may be ideas within it that we can apply to perhaps care homes and the shielding of people within that high risk environment.
I think that's a really good point about the care homes. Green zones and red zones would be, because they seem such a breeding ground for the infection.
Yeah.
Anissa, thanks a lot for that. It's a really interesting paper to present. Let's move on to the next paper, which is, I'm going to take this one. This is about myocarditis. So with my interest in the heart, I'll tell you a little bit about this. It's a case report of a 63-year-old patient who presented with apparent fulminant myocarditis. And so there was some discussion about this and some insights into it. So this patient presented with typical symptoms of COVID, a high fever, a cough, and they also had some exertional chest tightness. Here you can see the chest X-ray and some of the CT images, which show classical COVID pneumonia. And then they also noticed some cardiac abnormalities. So here we've got the ECG, which they said in the report actually didn't show any ST elevation. But I probably disagree with him on this one. It looks like a pretty risky ECG to me. If you look at AVR, first of all, look at the axis, look at AVR. It looks as though you've got a tall R wave in AVR, but actually I think this is largely ST elevation. Look in lead 3, this is where the QRS complex ends, and you've got ST elevation in AVR. The same happens in V1, where you do seem to have ST elevation to me, and you've got ST depression V3 to V6. So something was going on. They measured a cardiac troponin, and it was massive. I think they reported the wrong units, because it would have been 1.5 billion nanograms per litre, but I think it's probably a little lower magnitude than that, but still a very high troponin. And the patient had an ejection fraction of 32% on their echo. So they presented this as the first case of fulminant myocarditis that occurred in China. I'm not so sure. I mean, it would be nice to have some MR data, and it would have been nice, I think, to know what the coronary anatomy looked like, because we do know that patients with these viral infections can actually get a high incidence of ACS and STEMI. And I just wonder what was going on in the coronary arteries of that patient, given those ECG findings and the troponin. So it might have been nice to have explored that and see if actually this was coronary artery disease and a myocardial infarction rather than myocarditis. But the myocarditis does seem to be a real thing. Just to show you this paper from another group in China, showing that if you have cardiac injury as detected by a high troponin level when you have a COVID-19 infection, then your prognosis is much worse than patients who have a normal troponin. You see the difference here in survival rate, and that's just above the 99th percentile. Of course, it's going to be a continuum. The higher you go, the worse your prognosis. So it's telling us something important. And you may say that in this study, well, they're likely to be sicker if they've got a high troponin. They're likely to be older. They're likely to have more comorbidities. It may just be a sign of their underlying condition. Well, the authors did adjust for that, and they still found independent predictive value of troponin. So it does seem to be telling us something. And this wasn't the only case report of myocarditis in the literature. There have been others as well, where there are classical MR findings of myocarditis. So it does seem to be a thing. I'd say that we need to look out for it when you've got a patient who's hypotensive and shocked with COVID. Bear in mind that it might be myocarditis, because that might not be fluid responsive. And in fact, giving them fluid might be the wrong thing to do. They may need inotropes. So any thoughts about that, Simon? I don't know if you've got any thoughts about the clinical perspective of myocarditis. How does this affect your practice in the emergency department, knowing about this possibility and what you're going to do differently?
Sorry, not a huge amount of things differently at this stage, because I mean, what we are doing now is we're measuring troponin on all the patients who come in. So all the patients get admitted, get a standard panel. And I think we should be doing that to get a baseline and to see where things are going. I think your comment about fluid is a tricky one, because we do know from the UK experience, it seems that these patients are coming in pretty dehydrated. So lots of people are saying they've lost 5 kilos in a week with a COVID, and the week before they come to the ED. And of course, that's water. And there's been a lot of thoughts locally that we need to try and catch up and make people euvolemic. So don't be afraid to give fluid in those initial those initial few hours, and certainly within the first day. I think doing echo on these patients is potentially useful as well. The paper does talk about the echo changes, and I think Casey will probably be a better guide on that. So I don't know what Casey, you think about doing echoes on these patients when they turn up in the ED.
Yeah, I think doing an early echo can certainly give you some very useful information. Obviously, that is a bit limited by the skill level in your department and availability, but it's a very non-invasive test. And in terms of the infection control, it's actually pretty easy to do. So I think echo is probably good bang for your buck in this current epidemic. And if you see something that looks more like a heart attack, then as Rick said, maybe we do need to do that, because that's it may make a big difference to that individual patient, and certainly save a lot of resources potentially if they are in fact having a STEMI. You don't want to put them into isolation and leave them on the ward for a few days.
There's a big risk at the moment that we are missing myocardial disease in general. So I think getting some imaging early. So we're seeing late presenting MIs, and also people presenting with ACS who just happen to have COVID at the same time, as opposed to COVID being their major problem. So again, keeping that sort of clinical skepticism is important. But I think measuring them and measuring the troponin is quite important in all the patients who get admitted. I think most places are doing that, but I'd be interested to hear if other centres are doing.
Yeah, definitely. And I find it very useful. The question is, what does it actually do to change your practice? What are you going to do based on that troponin, knowing that it's elevated? At the moment, it's just good, I think, to know about that information, to add it into your overall judgment, but hopefully we'll be able to get some evidence as we go forward. I should move us on now, because we've got Casey's paper, and here we go. Sorry, let me come back to that. Casey, you're going to present a really interesting paper on chest CT. So playing to your interest in imaging, looking at chest CT.
Yeah, thanks, Rick. This is a paper out of Rome that was published in Radiology just recently entitled CT Chest Features of COVID-19. So this was a prospective cohort trial where they took 158 consecutive patients who presented to their emergency department with suspected COVID infections. So they were patients with fever, respiratory symptoms, dyspnea, or patients who had had known contacts of COVID. They enrolled patients over 2 weeks. Interestingly, they excluded patients that were going to have imaging for other reasons, such as a CTPA for a PE or a dissection. I've not seen many COVID patients live, but I imagine it's quite difficult to pick the difference between a PE and someone with COVID clinically. All of the patients then went on to get a 128-slice CT of their chest, and this was reported by 2 radiologists that had interest in thoracic imaging. So they weren't just, us lowly ED docs glancing at the screen. These are people that were very good at it. And they also went on to had the gold standard test. And this is something we can come back to, because all of these diagnostic studies do rely on a gold standard. And it's really very unclear in this epidemic what the gold standard actually is. So in this trial, the gold standard was 2 separate sets of swabs of the nose and oral pharynx 24 hours apart. So they ended up getting 2 swabs 24 hours apart. And if both of them were negative, they were declared to be a negative patient. Or if one of them was positive, they were said to be a true positive. So I don't know, we can argue later on about whether that's the best gold standard, whether there's some other clinical stuff we could be using, such as discharges or other outcomes, but that's what they did in this trial. They also excluded 2 patients from this trial because they had severe movement artifact on their chest CT. And I can imagine that these patients are particularly difficult to image if someone's breathing away at 30 or 40 breaths a minute. It can be quite difficult to get a good CT picture. The long and the short, though, is that when they put all the patients in and they tested them with the PCR technology as well as the CT, what they found was a sensitivity for CT of 97%, which is really quite impressive. But of course, as we all know, whenever you have a high sensitivity, that comes at a cost to specificity. So the specificity was only 56% in this trial. Now, I'm a big fan of likelihood ratios, as I know Simon is as well. And if you convert that to a likelihood ratio, what that says is that this is a bit like a D dimer in that it's got a very weakly positive likelihood ratio of about 2.2, but quite a good negative likelihood ratio of 0.05. So it's a good test for ruling out disease. If you've got a plumb normal CT, you probably don't have COVID, is what this is saying. Of course, likelihood ratios are quite a good way of looking at this, because all over the world we're seeing remarkably different prevalences, say between the UK or the USA versus what's happening in Australia or New Zealand at the moment. And so it's really important to be able to interpret these tests in the light of what the community prevalence of the disease is, because a CT of your chest in New Zealand means something very different to a CT of your chest in New York at the moment, because you're going to see a lot of false positives in New Zealand compared to New York. So what I'd say is that the key points that we should take away from this paper is that of the imaging that was done, of the true positives, there was a very typical pattern that they saw. So 100% of the true positives had what they called ground glass opacity, and it was usually in more than 2 lobes. In fact, the more lobes of your lungs that were involved, the much more likely it is that you were going to be a true positive for COVID. And if it was bilateral, and particularly posterior ground glass, were more likely. The other really key thing that I picked up from this was that there was some signs of showing enlarged subsegmental pulmonary vessels, so greater than 3 millimeters was the cutoff. And this is a really interesting finding, because this is not something that we see with a lot of other chronic lung disease, which could cause false positives on a study such as this. And so it may be that that's a very specific sign for the COVID disease. I don't really understand why it would happen. There's a lot of ideas around microthrombi and other things going on with pulmonary hypertension in these patients, but it's quite an interesting finding and has been seen in a couple of other imaging trials as well. So it may be that that is something that we can use to differentiate this from other lung disease. Of course, the very interesting thing was that the CT changes, there was quite a lot of them, they didn't seem to differentiate between the severe and the less severe. So even the patients that were sent home and treated as outpatients were just as likely to have these different CT changes. So as we always say, the better a test gets, the smarter the doctor looking at it has to be, because if you've got a great test that's very sensitive, you do need to have a sensible doctor looking at it, because you'll make a lot of random decisions if you just base it off the imaging alone. So look at the patient as well, I guess, is what that tells me. So that was my takeaways from this paper.
Thanks a lot, Casey. Simon, you had a question about the gold standard.
Yeah, so Casey, the gold standard in this was the PCR test, wasn't it?
Yes, that's right. So two batches of PCR 24 hours apart. That's correct.
I mean, we do know the PCR test is not perfect. So is there a possibility here that we're testing what might actually be a superior test against an inferior gold standard? And how do we, it's always going to be tricky if potentially one test that you're performing against an imperfect gold standard may actually have better performance in some respects. Do you think that's a possibility here?
Yeah, that is really very possible, I think, in this, because I think you guys discussed this on your webinar last week, that the gold standard is really difficult with this new and evolving disease. And to be honest, I don't think that 2 PCRs are a great gold standard. And if they were sort of 80% sensitive for this disease, then that would be worse than the CT potentially. So I really don't know. And I think, to be honest, I think we need to get bigger trials with more data which have hard clinical outcomes, so final diagnosis or autopsy results, for example, which can really give us a much more discrete idea as to what the actual gold standard should be.
And Paul, I think you want to come in on that.
I was just going to say that if by analogy with other respiratory infections, you've got an upper respiratory tract infection, so you swab the throat and it's positive. As it descends into the lung, the throat, the amount of virus in the throat might be lower, and that would explain why some of these are PCR negative. What you really need is sampling from the lung, which is, of course, more difficult. So if you did bronchiolar alveolar lavages on these patients, you would probably find a virus in the ones where the CT is positive and and the PCR is negative in the throat. As
Yeah,
I said, it's more studies needed.
Yeah,
Looking at
the problem with
the
problem with the bronchoalveolar lavage is that you're going to get spectrum bias then, because you're really only going to be looking at the ICU patients, the really sick ones, because the well patients aren't going to put their hand up for a scope, I don't think.
What I would like to see is the studies from patients who are on ventilators looking at virus in the ventilator fluid, because that's really seeing what's coming out of the lungs, and that would be a really good one to judge this CT against.
I thought the other interesting thing, as you say, Casey, was about the vascular dilatation, because ordinarily we don't see that, but it could be one of the mechanisms for why we see such a dramatic VQ mismatch in this group of patients, and in perhaps why proning seems to have such a radical and rapid effect in improving hypoxia in this group. So yeah, it may be a specific thing for the diagnosis, but also actually clinically, I think that might actually be quite important.
Yeah, for sure. It certainly seemed to be more of a posterior phenomenon. So yeah, if that may be why proning works.
Brilliant. Thanks very much, Casey. It's been a real honour to have you present a paper and join us for Journal Club today. And that was a really interesting paper. So I'll move us on. Charlie, you want to say a couple of things. First of all, to tell us about the RChem top fives and how we submit, and also about the Kira study. You're on mute, Charlie.
Sorry. As always, if you've seen an interesting paper, please share it with us. We've got a Google form, which we've linked on Twitter, and we'll send out the link again after this. And it'd be absolutely fantastic to have people from far and wide submitting papers. If you put a little paragraph in it, then it'll be considered for inclusion, and we're looking to include as many people as possible. So please put something in there. The next announcement is regarding the Sierra study, for which the CI is Dr. Tom Roberts, who's the Turn Fellow. It's the COVID-19 emergency response assessment, and more than 6,000 emergency medicine clinicians, anaesthetists, and intensivists replied to the first survey, but it was one of three. The first one was put out before the pandemic, and the second one is to be put out on or just after the peak. And the Sierra study group believe that we are on or just after the peak at the moment. And so in the next hour or so, all of those people who replied to the first survey will be getting an email for the second survey. And it'll be absolutely fantastic and imperative for the study if everyone could please fill in that second survey and help us find out how this pandemic has been affecting frontline workers and their mental health.
Brilliant. Thanks a lot, Charlie. And just end by showing the references. If it's okay, we'll share this again via the St. Emlyn's blog, so that it's readily available to anybody who wants to access it. Simon, you want to come in? You're muted.
Just on the St. Emlyn's blog, we are going to put the stuff up on there. There's been some stuff on Twitter whilst we've been going on about the confusion about whether the RChem CPD bulletin is the same as this. They are slightly different, partly because we've got two amazing virologists that we can get onto this journal club who can explain the papers in a much better way when it gets a bit technical. So there is a little bit of variance in that, but we'll put all of the data together from both so people can see all of the references, regardless of how they come to you, via this or via the CPD bulletin.
Brilliant. And Ian Beardsley's done a fantastic job of editing last week's webinar. It made me sound much better, far fewer ums and ums, so massive shout out to Ian. Thanks for doing that. And thanks to everybody for joining us. Sorry about the little hitch with joining the webinar. I'll try and sort that out for next week, because we'll be back same time next week on Tuesday, 11 o'clock British Summer Time. Thanks to all the panel for joining us as well. We really appreciate you giving up your time and giving us your expert insights. Take care, everybody.
Bye-bye.
Right.
Bye.